Hello, everyone. Thank you for joining us today for a wonderful webinar on the Care Dividend, how and why countries should invest in long-term care. Today, we'll be talking about the Care Dividend book, but we are also joined by a wonderful panel of experts from around Europe who will bring different arguments from very varied perspectives, together arguing for increased public investment in high-quality, universally accessible long-term care. And we'll try very hard to explain why this investment benefits everyone, not just the long-term care system itself, but the individuals, households, families, health systems, economies, and our society in the most general terms. For those of you who might end up having internet problems or are very busy and have limited time, here is the bottom line up front. Today, we will combat some of the most prevalent myths around long-term care. Do, as population age, investment in long-term care bankrupt welfare systems? No, not necessarily, depending on what we do today. Is long-term care investment a sunk cost that drags down and limits economic growth? No, not at all. On the contrary. Will investment in long-term care limit availability of resources to invest in health systems? Again, not at all, not necessarily. Does investment in long-term care benefit only older people and adds to intergenerational inequalities? Plain wrong. On the contrary. Finally, is there a role for the state in long-term care? Or should the private market just take over, do its job, and deliver care effectively? No, there is an important role for the state, and private markets alone in long-term care don't work. To tell you more about this and the general arguments that we make in the Care Dividend book, we're joined today by my colleague John Cylus, who's the head of the London hub of the European Observatory on Health Systems and Policies, and he's also a senior health economist at WHO Europe. John, you have 10 minutes to set the scene for how and why governments can and absolutely should invest in long-term care today.
Great. Thank you, Stefania. So in my brief 10 minutes, I will try and give a bit of the motivation for why we decided to write this book. And I'm going to start off because this is a session about aging and long-term care. I think that we always need to start these sessions with a figure that shows that populations are aging. And so this figure here comes from Spain, but it reflects patterns that are seen across Europe. So due to reductions in fertility and longer life expectancies, the age mix of the population is changing in high-income countries, not just in Europe, but across the world. And especially since we're talking about long-term care, it's not just that the age mix of the population is changing, but the size of the population at older ages is increasing. So if we look here in Spain, in 2024, about 3% of the population was over age 85. By the end of the century, this is expected to more than quadruple to about 13%. And again, this is a pattern that's really seen across the region. Now, as Stefania said, aging itself is not necessarily a challenge, not necessarily a problem, but what might determine whether or not it's a problem is how well people age and whether they age in good health and whether they'll require long-term care. And so to understand this question, we can look at this indicator of healthy life years at age 65 and look at this as a percentage of life expectancy at age 65. And the reason this is a good indicator is because healthy life years are based on measures of functional limitations, and functional limitations are an important predictor of needs for long-term care. So here we can see changes across countries between 2005 in blue and 2022 in orange. What you see is there's a lot of variation across the region. So in a country like Norway, around 70% of life expectancy at age 65, around 70% of the remaining years of life are spent without functional limitations. This is improved over time. Whereas if we look on the right, if we look at a country like Spain, which since I showed the population data, in Spain, although people are living longer in 2022, compared to 2005, fewer years, a smaller percentage of those additional years after age 65 are spent in good health. So only about 45%. And if we look at Latvia, it's closer to 35%. Sorry, 25%. And of course, even though we have populations aging across the region, and in many countries, people with increasing needs, public spending on long-term care has historically been very low. So this figure here, this shows per person average annual growth in government spending on long-term care. It's per person over age 65. And I've broken this down into two time periods. So in orange, we have 2013 to 2019, so the period before COVID. And in orange, we have 2013 to 2023, which is the entire decade. I think there's two things to point out from this figure. The first is that if you look on the far right of the figure, there are a number of countries that seem to have very high average annual growth in per person spending over age 65. But most of these countries, Estonia, Greece, Lithuania, they have very low levels of spending on long-term care. And so this high rate of growth is coming from a very low baseline. So they're still spending very low levels. The second thing, perhaps more encouraging, is that if we look and we compare the blue bar to the orange bar, generally in most of the countries, the blue bar is higher than the orange bar. And what this means is that since COVID, countries have started to give more attention to long-term care. They've increased their spending. There's been a bit of a catch-up in spending on long-term care, even though levels are still quite low. Now, these very low levels of spending, one of the consequences of very low levels of public spending is that a lot of long-term care spending is out of pocket at the point of use by people who are receiving care. And just to put this in perspective, in this figure, I'm comparing in orange, in blue, out-of-pocket spending as a share of health spending, compared in orange to out-of-pocket spending as a share of long-term care spending. So you can see our countries depending more on households to finance their own care in the long-term care sector versus in health. And what you see for the countries above the dotted line is that in many cases, even in countries that have very well developed long-term care systems, there's a tendency to depend more on households to pay for their own care. So countries like Germany, for example, the out-of-pocket share of long-term care spending, just the health portion of long-term care spending, is around twice that of the health sector. Same in France, other developed long-term care systems like Austria, Ireland, the UK, again, much more of a dependence on households to pay their own bills rather than the public sector. And I should note also that even these countries that are below the dotted line, there may be some undercounting of out-of-pocket spending on long-term care, as this is not collected as reliably as health spending. So this raises a question. So why are policymakers, why have they historically been so afraid of population aging and long-term care as well? And so we have this other book on the politics of aging that we published a few years ago, which tries to understand this question. And a few of the hypotheses that we explore in this book are, first off, that population aging is a convenient excuse to not invest in public services, not only long-term care, but the welfare state in general, because of this idea that aging is the boogeyman. And as populations age, it will become unsustainable. And so better to not spend than to start spending and have to make cuts, or maybe it's an excuse to make cuts. Another reason that policymakers may avoid this topic is because of inequalities in wealth, gender, and race that make it so some people don't need services to be funded publicly. So they may prefer to pay themselves for an immigrant to look after their older relative, or it may be expected that a woman will leave the labor market to look after an older relative. And so these inequalities, these expectations make it so that perhaps there's less demand, less of an impetus for publicly financed care. Also could be that fragmentation in the sector makes it too difficult to do anything. Again, cultural expectations that people will look after their own family members. And lastly, and Stefania mentioned this at the beginning, many people may think that long-term care is something that only benefits other people, that benefits older people, that benefits, that it's not something that concerns them. And so a big part of this book, in addition to chapters that look at best practices in service delivery, financing, determining eligibility, quality, we have spent a lot of time looking at the evidence on how investing in long-term care benefits not only care recipients, but societies, economies, health systems, and household finances. Just to give a flavor of some of the findings, in health systems benefit from investments in publicly financed long-term care and improving access to long-term care in general, in part because it can reduce pressures on hospitals. So in countries where there's very weak long-term care systems, people end up in hospitals even though they don't necessarily need such intensive services. And this not only puts them somewhere where they don't want to be, but also is more expensive oftentimes, and uses resources that could be used for people who do require acute care. Improving access to long-term care also benefits the economies, but benefits the economy in part by increasing labor market participation among would-be caregivers. So as I mentioned, oftentimes people leave the labor market to look after older relatives, particularly women. By strengthening long-term care and creating high-quality options for older people to receive care, this enables people to stay in the labor market, which is good for the economy as well as for their own household finances. And I mentioned on the topic of household finances already, the high out-of-pocket burden of long-term care in many countries. The onset of providing care also is associated with an increased risk of poverty, probably in part because people leave the labor market to look after somebody. So there's an effect on household finances. And lastly, on societal well-being, that was a lot of animation, sorry. There's lots of really innovative ideas that improve access to long-term care while also addressing other challenges. So for example, in some countries, there are initiatives where people are cohabitating with a younger person, so helping to address housing crisis, and that younger person helps to address some of the care needs of an older person. This is my final slide. Just some overarching takeaways from the book and some things to think about as we move into the panel. So I think that the evidence is very strong that long-term care, improving access to publicly financed long-term care has great potential to benefit not only the care recipients, but health systems, economies, households, and societies. But as Stefania also mentioned, it depends on how long-term care system is designed. And so I think this raises a lot of interesting policy questions for, okay, if we're going to invest in long-term care, what should that look like? So here, just 4 basic principles to sort of guide us. I think first is that long-term care should be publicly funded. This is important, obviously, to make sure that access remains equitable so people can access care based on needs, not based on their ability to pay. Although this raises questions about how to make this financing sustainable, especially as working age populations shrink at the same time that the size of the older population is increasing and demand is increasing. Similarly, everyone that has care needs should be covered, but this raises questions about how to design eligibility rules, again, with an eye for maintaining financial sustainability. Long-term care systems also should not only benefit care recipients, they also need to benefit carers and make sure that these people, informal carers, for example, maintain access to pensions, even if they leave the labor market, make sure that they don't themselves have burnout. And they should be designed with clear objectives. So the long-term care system, if it's designed things like keeping people at home for longer or in the community for longer, or with a more personalized care plan based on people's needs, that you should come up with these objectives and then design the system accordingly. Of course, there are other important things to think about. I'll just flag as we move into the panel, the role for the private sector and how to make sure that the private sector works towards this objective of equity of access. Whether benefits should be cash or in kind, and importantly, a challenge facing not just long-term care but also health systems, workforce shortages. How do you maintain the recruitment and retainment of long-term care workforce? So with that, I hope that provides some motivation, not just for the book, but also for the panel. Thank you, Stefania. I hope I stuck to time.
Almost. Thank you so much, John. That was fantastic. Indeed, a very broad tour de force. The messages, I think, are clear and are worth repeating over and over. It is important that we all recognize, in the face of population aging, long-term care provision is a challenge for every country around the world. But this is not an insurmountable challenge. We should not let awareness of the magnitude of this challenge paralyze all action, because as policymakers, as health and care providers, as researchers, and as advocates, we all have agency. So overwhelmingly, the message of the book and the message that we're trying to transmit today is that there is scope for action. And the decisions we make today will shape very much our own experiences of aging and also the care we will receive in the future should we need it. With that overview, thank you so much, John. I'm going to invite Dr. Ludovico Carino, who is Associate Professor of Public Economics at the University of Trieste and also a visiting senior lecturer at King's College London. Hello, Ludovico, welcome. I'm going to ask you for a short reflection, 3 to 4 minutes, on how differences in eligibility criteria across countries are shaping access to care, but also the quality of long-term care services that we offer. And as an Italian and having a lot of experience in analyzing the Italian long-term care system, maybe we can then end with a reflection on how the experience is of Italy and its recent long-term care reform are shaping our understanding of how we can use eligibility criteria to make long-term care systems more accessible, more inclusive, better quality. The floor to you. The question was easy, right?
Yeah, thank you, Stefania, and thanks everyone for watching this. I would say, first of all, we have evidence that long-term care delivered through public channels, through the system of assessment of needs and eligibility rules, works. It delivers improvements in health for older people. And this is important. It shouldn't be taken for granted. We have causal evidence on this for some countries in Europe. This has spillovers that have intergenerational spillovers, I would say. So on their caregivers, on the spouse of this person, but also on, I don't know, potential young caregivers. So we have the possibility, by investing in long-term care, to deliver more productivity for firms, improving the labor market, and even enhancing education of younger people. But as you said, Stefania, of course, access to long-term care is regulated by eligibility rules. We have, and we discuss in the book, that several apparently even perhaps small or insignificant aspects of eligibility rules are actually crucial. So whether the rule designs the potential demand more close to, I don't know, prevention, rather than acting ex post, this is completely different. It shapes completely differently the potential demand. Also, whether it focuses on helping the caregiver or the care user through the caregiver, perhaps this completely changes the access and the potential quality of care. And finally, what kind of health conditions are included, how they are combined. There is really a maze across Europe and beyond, because there is not a unique definition for loss of autonomy, and this clearly gets reflected into how the rules are designed. So I would say governments are taking this seriously. It really requires a lot of careful consideration how the rules are shaped. They make a lot of difference for people and their outcomes. The Italian case, I think it's a very good example. We have an old cash benefit, which has a unique level of assistance for everybody who is eligible. Changing this requires two things. First of all, adding a new definition of loss of autonomy, and Italy is struggling to do that. They are working very hard to do that, but so far we don't have a new definition of loss of autonomy. And second, political economy-wise, some people might lose access. Some people who before were receiving something now with a new definition might not. And this, of course, slows down the process. So you would need more budget, essentially. Right. And also budget is tight. The last point I would say in Italy is part of this, let's say, is facing this problem, the definition of long-term care needs. If governments adopt a sufficiently narrow definition of what long-term care is, for example, services for people who are bedridden, in extremely difficult conditions, then the potential demand for these services is small. And you could argue we don't have really a big problem. But we know that long-term care needs are there for people, regardless of how governments define the needs. Governments are there for real people, real problems for real people. So it's important not to set a definition which is too narrow, because it risks saying that there is not a problem when actually people are facing problems of need of care. I'm going to be very quick here, and I'm happy to expand this later.
No, maybe you can give us in 20 seconds a very short pitch on why it is worthwhile to choose broader eligibility criteria and to emphasize more, as you hinted, a prevention-oriented approach, intervene early, support maintenance of functioning, and delay decline. Are some countries going into the direction, and what is the economic case for that? Because as you say, demand would increase, but maybe over the long term, there are other benefits we can expect.
Yes, essentially the issue with the narrow definition is that you pretend that the costs of acting in this way are small. People will manage. So we have a very tight definition of care needs. So many people will be left out. Who will take care of these people? Families with a huge spillovers, which are invisible if you want them to be invisible, but are very, very real in economies. And therefore, this is the reason why a broader definition can internalize this cost and reduce the negative externalities, essentially, of care needs. Meaning, being more realistic on costs of not acting, because acting early will surely deliver better outcomes for economies.
Thank you so much, Ludovico. That's fantastic. Brilliant summary. Thank you. We're going to move next to our a panelist from Slovenia, Eva Šarek-Zver. Eva, I hope I'm pronouncing your name correctly, and you'll forgive me if I don't. Eva works at the Institute of Macroeconomic Analysis and Development of the Republic of Slovenia. She has a long experience in academic analysis and has been looking carefully at the Slovenian long-term care reform. I think all of you know, just a few years back, Slovenia adopted a landmark long-term care act, which really overhauled its care system completely, from the financing to the organization to the delivery of care. So, Eva, maybe you can start with a very short summary of what were the main features of the reform for those participants who might not be familiar with it. But hopefully you can also share some of the difficult experiences of implementation. Yeah? What are some of the challenges that every country needs to be aware of once a long-term care reform is being considered? The floor to you.
Thank you, Stefania. Yes, like Ludovico said, one of the key features was how to standardize this needs assessment tool and procedure. What are the eligibility criteria to enter the new system? And we started to prepare the new system already 20 years ago. So it started in 2005. And somehow we based our needs assessment tool on the German system. And then we got some EU financing in 2016 for the pilot project to test this eligibility criteria and to test actually a needs assessment tool and the entry points to the new system. So, but if I start with the problems of implementation, it took 20 years, yes. And the main reason for such a long delay was the question of financing. So specifically, where to secure additional resources for the new long-term care system. And during these 20 years, the private spending, out-of-pocket spending, was increasing rapidly. And everybody saw this. It was growing much faster than in the health system, so the out-of-pocket spending for long-term care. And the rights and benefits overlapped across different social security systems, including health, pension system, and social protection system. And then an important step was done in 2017 when the stakeholders and the government somehow it became clear to everybody that the long-term care services were financed in Slovenia mainly through the health insurance system. So that the health insurance system has to get involved in the implementation and in the discussions about the new financing model of the long-term care. Before that, they somehow avoided these discussions. And then the next important pressure was from the European semester 2019, so before COVID even, when Slovenia received country-specific recommendations, explicitly linking long-term care reform to the national reform agenda. And then during pandemic, these recommendations were tied to the recovery and resilience plan. So the adoption of the reform, and due to this pressure, we could say that the things moved on with the new act. And
Eva, can I ask you, you
yes.
mentioned a little bit this overlap between the health and social sectors and how they both need to come together. Is this one of the main challenges of implementation? Is this something that Slovenia has figured out, and how?
Yes, I could say this in all these years back. This was one of the main challenges. So it was the preparation of the reform was for some years at the Ministry of Labor and Social Affairs, and then it moved to the Ministry of Health, and then back to the Ministry of Labor, and they were switching this and nobody wanted to take the responsibility. And even if we convinced them that the health system has to work together with the Ministry of Labor, until they didn't took the responsibility for this, nothing moved on. But then finally, this was somehow accepted, and yeah, these pressures from the epidemic and from the recovery from the Europe came. And then in 2021, it's also interesting, it was adopted a new long-term care act, but without financing basis. So still we didn't know how the system will be financed. It was only stated in the act that the new social contribution for long-term care will be adopted, but when and how and what will happen, nobody wanted to take the responsibility. Until the year 2023, and then the new financing model was finally adopted. But it was somehow under the pressure of this linking it to the recovery and the resilience plan. And now in 2025, in 1st July, we started with the new contribution rate for the new long-term care insurance, and it amounts 1% of the gross salary, and is paid by both employers 1% and employees 1%, and pensioners contribute 1% of their net pension. In addition to these contributions, it's also in the state budget. Also, state budget should allocate the maximum. It's set in the long-term care act that the maximum of 190 million. So that would be 0.2% of GDP. Would be added to the long-term care by the state budget. So that's a bit unsustainable for the future. And there's an additional option to implement to introduce the co-payments of users from January 2028 onwards, if other funding sources prove insufficient. So, yeah.
Thank you so much, Eva. That's fascinating. And the message I take is that it's all good and well to imagine the long-term care system that we desire. Although, as you said, it took 20 years to do even that. Once we do, we still need to face the reality of where are the resources going to come from? How are we going to sustain this in practice? And these are conversations that need to happen across sectors with shared responsibility and with shared contributions from your description at the very end, contributions from individuals themselves throughout their life course, from governments through taxation, and potentially also from other private resources through co-payments. Thank you so much, Eva. We might come back to some of these topics in the questions and answers. Please keep the questions coming, and we will bring as many of them as we can back to the panelists at the end. I'm going to invite now to join us to follow up a little bit on this financing economics argument, Dr. Brendan Walsh, who is Senior Research Officer at the Economic and Social Research Institute in Ireland. Brendan has a very long list of academic and applied policy research on long-term care specifically. But what stands out to us, Brendan, and maybe what we'd really like to discuss with you today, is the situation and the role that private equity is playing in long-term care, and particularly in the nursing home sector. Ireland is a good case in point, but many other countries in Europe are experiencing large increase in the market share of private equity funds, especially in the long-term care sector, long-term facility-based long-term care sector. My apologies. I'm thinking now France, I'm thinking of Spain, and I'm sure many, many others will recognize this trend that is deepening. So, Brendan, my question to you is, what evidence do we have on how this ownership model might affect care quality, maybe staffing conditions, since workforce is already one of the topics that keeps popping up in the Q&A, and the continuity of care?
Thanks, Stefania. So maybe first a very quick kind of history lesson into how we got here. So going back to John's points, the states have reduced their role in long-term care provision for quite a number of years now, and they have introduced policies to attract private providers into long-term care. And if you take residential care in Ireland, for example, 20 years ago, the majority of beds would have been publicly provided, and now over 80% are privately provided due to this policy shift. And then in the last decade or so, there has been a further evolution away from kind of smaller, regionally distributed private care homes towards more corporatization within the sector. You know how you now have private equity funds entering the market, and they have become the dominant providers, like you say. And this has kind of largely happened under the noses of policymakers. And these new ownership models, they're having key structural impacts on the long-term care market in Ireland, but also internationally. There are now more consolidated markets. There is increased state reliance on these operators, so you have kind of a too big to fail aspect. Access to long-term care for people now is often determined by the willingness of providers to operate in localities based upon profit expectations, as opposed to a need existing in a locality. And then you mentioned some of these already, but provider failures are having much bigger impact on individual users and residents. And there have been kind of detrimental examples of this in Ireland, in Spain, in England, and in France as well. And these new models have also introduced complex financial structures called OpCo-PropCo. And they've been introduced largely that they separate day-to-day care from the financial benefits of care. So there's much more money now flowing to rent and fees, and maybe less money flowing into the provision of care to individuals themselves. And there have been a number of studies out of the US, but also here in Europe, showing this increased private equity ownership and consolidation of long-term care. It does result in tighter workforce conditions, in lower continuity of care, and often poorer outcomes for users as well.
Yeah, that's very well said, Brendan. Great tour de force from your side as well, and the history lesson well taken. I would invite our participants today, our public, to maybe put in the chat some comments around whether this topic is being recognized as a policy priority in their country. If it is a trend that they are observing in their own countries, it's definitely something we'd be interested to look into closely with a more comparative lens. But maybe again, coming back to the experience of Ireland, of France, of Spain, where you have said studies have been carried out, what are governments trying to do to manage this trend, to get ahead of it, to mitigate quality risks? Do we have maybe some cautionary tales and some encouraging recommendations about what can be done?
Yeah, I think getting ahead of it is the first port of call. I think we have to be honest and understand this private equity genie, it's not going to be put back into the bottle, and it'll likely be there for a long time and continue to evolve. And I think there are kind of two key policy options we could implement in the short run. The first option is to ensure policymakers and regulators improve information and transparency on how providers are governed, financed, and operated. The US, which is, I suppose, the most experience with private equity in long-term care, they've had policy proposals in this area as far back as the Affordable Care Act in 2010 to make ownership and financial control structures of care providers visible and usable for oversight. And then more recently, CMS Medicaid have implemented some provisions making it mandatory for skilled nursing facilities and nursing homes to inform them on who owns, controls, manages, leases to, or provides key services within a facility. And I think policymakers in Europe and regulators in Europe could do something similar. And then second, maybe the more difficult option is to reinvest in public provision. In many cases, the state will need to act as a backstop in those areas where the private sector is not willing to provide care. But to a large extent, this is also good for those corporations because it's essentially a form of cream skimming, as there's no onus on them to locate in less profitable areas. And I think ensuring the state remains a viable competitor to the private sector is important, and that the state themselves continue to aim to provide a large percentage of long-term care firstly, and have it as an option for individuals to receive this public provision of care.
Oh, brilliant, Brandon. I was trying to make note of that. The public sector remains a viable competitor to the private sector. I love it. I think it says so much. Also, in shaping our own understanding of what the role of the state, of providers, for-profit, non-for-profit, public-private are really in the long-term care sector. Wonderful. Thank you so much for that great and very succinct intervention. Please come back with questions for Brendan in the Q&A. And our last speaker in the panel today is Flaviana Teodosiou. Flaviana works at the European Commission for many years, 15 at least. And currently she is leading the long-term care team at the Director General for Employment. This is the team that is coordinating the implementation of the European Care Strategy and the Council conclusions on access to affordable, high-quality long-term care. So Flaviana, of course, to you, we turn to understand where some of these resources, which are clearly direly needed, might come from. So since the adoption of the care strategy, the European Commission has played an important role in accelerating investment in long-term care. And I think Eva said it brilliantly. The catalytic effect of the RRP funding has had in Slovenia is certainly not an exception. Many other countries have experienced this. But what I really would like to ask you, because I assume this is what's on many participants' minds, based on the past and the current funding programs, what type of long-term care initiatives is the Commission most likely to support in the future? What types of investments and what types of funding schemes should we expect in this area? Please, the floor is yours.
Thank you, Stefania. Great to be part, an honor to be part such a great panel, and I'm bringing my little bit to this big puzzle. Also picking up on some of the aspects that were highlighted by John and Brandon also when it comes to funding. And to the importance of public funding. But let me maybe just to have 30 seconds on the bigger picture. So indeed, as you said, the care strategy and the council recommendation on long-term care did act as catalysts for reforms and investments across the member states. We know that LTC is a national competence, but EU plays a supportive role. You've asked me to focus particularly on funding aspects, but I cannot stress enough how EU funding is only one of the many ways in which we are supporting member states' action in the area of long-term care. We do many other things, and to not waste precious speaking time, I will put those things in the chat as links. But basically, the conceptual approach that we take to long-term care is that long-term care is a public good. It's a key function of social protection systems. Actually, the treaty base of the long-term care recommendation is modernization of social protection, and this is no accident. It's also a driver of gender equality and a smart investment. And these smart investments are documented in the book. We are also doing further work to document the multiple returns from investing in long-term care. So now, as to what we have been doing so far and the link with the future, I think that the key word is indeed continuity. As the Slovenian colleague has shown, there is a big that it's a tandem between the policy guidance and the type of funding that we are offering. So just to put a few numbers out there, currently, so there are two main funding streams for long-term care investments and reforms in the member states under the current financial framework. The Recovery and Resilience Facility, under which some more than 8 billion euros have been invested by the member states in their long-term care systems. 2/3 of the member states have done reforms and investments, and this is maybe worth highlighting, that it's not investments without reforms, and it's not reforms without investments. It's both going together and creating this virtuous circle. The areas in which we've put focus is really around person-centered and integrated care. This continuation of the institutionalization and stepping up provision of home care and community-based services, huge investments in workforce, be it training or reskilling, and so on and so forth. So just I was looking through what we've been funding under RRP: community nurses, skilling, upskilling, daycare, community and home-based care, a lot of also infrastructure upgrades, because this is also not unimportant. While shifting towards community and home care, also having better care infrastructure, residential care is also important. And also kind of catching up with the times, investing in energy efficiency of the facilities, or also equipping them with the needed digital infrastructure that improves the quality of life of persons who use these services. For instance, in France, these digital investments helped the use of individual electronic accounts for residents, so to really have person-centered care. So this is the way these things work together. Under the ESF, so the European Social Fund, also nearly 7 billion were spent by 22 member states on health and long-term care, and policies range from active and healthy aging measures, again, system resilience, improved working conditions, and so forth. So under ESF, there's no funding for infrastructure, but there's funding for everything that is soft measures. So we expect under the next MFF more of the same. This is a very early stage and I don't have a crystal ball to see where the negotiations will lead up to. We are still some 1 year, if not 2 years, away from the final decisions. But what we put on the table at the European Commission is a 2 trillion strong multi-annual financial framework, with at least 14% of the national allocations that should go in the direction of financing social reforms and investments. And of course, that under this long-term care is a key component, because as shown by the other speakers, this links to social inclusion because of affordability, but this also links to the labor market because of the workforce dimension, and it brings returns across the board. So we hope that as negotiations advance with the co-legislators, this will be at least secured, if not the level of ambition raised. As to the enlargement and, let's say, neighborhood aspect, so there will also be continuity. There is a proposal related to a single external financing instrument, which is called Global Europe, which would cover enlargement and neighborhood and development cooperation. So under this program, we'll continue to support candidate and potential candidate country to align acquis and prepare for membership, and there will continue to be space for investment in long-term care as well. So
thank you for bringing that in, because I think our audience spans beyond the borders of the EU. So that's definitely good to know. And Flaviana, thank you for pushing for us. It's good to know that the long-term care agenda is strongly represented in the Commission. What role can we all as a community, from each of our own perspectives and positions, from advocacy, civil society, all the way to policymakers, what can we do at this point so that in 2 years' time, when the multi-annual financial framework is agreed, it's one that recognizes the true societal economic importance of investment in long-term care, other than be patient?
No, because it's a very good question, and to the extent that we are past the documentation stage, because the Commission did put the evidence forward, also drawing on the many resources that the research community has developed about the returns to investment, about the multiple dividends. Now it's very much about really acting as, I'm talking now for the European space, acting as simple engaged citizens and talking to our MEPs. This is one thing. So national organizations know their MEPs and can engage at national level this time in order to secure a good visibility of this policy area amongst the many others. And also to secure not only that the next MFF is ambitious when it comes to social issues, but also that their own national spending, and here I come to a point which was a bit discussed in the chat, that their own national spending is sufficiently ambitious, because EU funding does not replace adequate national funding. And here the situation is not, how should I say, it's highly heterogeneous, to be very elegant, to put it very mildly, because we have a huge discrepancy across the EU member states when it comes to national spending. So our 1.7 average of spending covers between 0.1 and 3.8% of GDP. So here you have a huge spread, and we know that insufficient spending correlates, as John has made it very clear, with poor outcomes. Out of pocket, workforce ratios, bad quality, what have you, it's there. So
thank you, Flaviana. That's actually well, we end on a positive note. Once again, we all have agency, we all have a role to play. None of us needs to feel defeatist about the challenges ahead, although these challenges are not indifferent. But I think it's a perfect transition to the Q&A. And Flaviana, you already made a reference to a bit of a back and forward in the chat. Erika, will you take us through?
Yes, so it's been a very lively chat box, which is always wonderful to see. People have been sharing fantastically interesting resources there. Couple of questions about the Nordic countries, so Finland, Sweden, Norway, and their relative success. So they've got long life expectancy, which is fantastic, but they appear to be able to contain spending. So if someone, maybe John or the others, would like to weigh in on that, that would be really interesting to hear. There are also people asking about the private equity companies and what is known about how they are trying to shape policy at the moment and the role that they are playing in the policy process. And then also, given how decisive recovery plan funding was in Eva's case study on Slovenia that she presented, what are the chances of this kind of big, bold reform actually being implemented without European funding? Is there the stomach and the resources available to do it? So yes, hopefully.
Erica, let's stop with that. Let's do this first round of questions. Who wants to jump in on the first one around spending Nordics and the
Sure. I'll jump in very, very quickly just to say it's definitely true if you look at the healthy life expectancy that countries like Sweden, Norway in particular do very well. I think it was a misunderstanding. The long-term care expenditure data that I showed was the average annual growth rate, not the level. So actually Finland, Sweden, Norway actually spend relatively high levels on long-term care, at least compared to other countries. So total long-term care spending in these countries is between 2 and 4% of GDP. But actually, I want to just point out or direct our attention more to this idea of the healthy life expectancy and why do we see that these countries do so well. I think it links back to Ludovico's point and Stefania's point as well about the importance of prevention. So this is not directly attributable to spending in long-term care per se. This is about spending over the life course. This is about the fact that these countries have, especially compared to other EU countries, very low smoking rates. They have relatively low alcohol consumption. They've done a lot to address cardiovascular risks and cancer mortality. So I think really having this sense of and incorporating this into thinking about eligibility criteria for long-term care services, the importance of prevention to make sure that people age in good health really has an impact on their later demand for more intensive long-term care services.
That's great, John. Ludovico, Flaviana, do you guys want to add anything on what John has said?
No, I'll just add that Nordic countries have decades of history of spending on their welfare state on many dimensions, not just long-term care. And this clearly has an effect on human capital accumulation during the foundations of the countries. We see some results today, which also means that they can do cost containment when a major crisis erupts because they have a solid foundation. So I would just add that.
Indeed. Yeah, thank you very much. No, point well taken. It takes decades of sustained investment to see any impact on outcomes like life expectancy or reductions in disability adjusted life years or DALYs. Okay, should we move to the next question? Brendan, I think that was more directly addressed to you, but once again, I invite everyone else to jump in. It was around the role that private equity is playing in policy design and shaping policies, maybe what kind of power the industry holds on how policy is being shaped in long-term care. Please.
Yeah, they certainly have much greater direct impact on how policy is being shaped. And when you think about kind of private equity funds, the reason they enter the market is because they understand there's quite a lot of money to be made, and there were very few barriers to entry for a lot of these corporations. And I suppose as an economist, this isn't surprising because, when you have a liberalized market and you have a state which, were quite clear that they want to grow private provision in terms of long-term care, and this liberal market is allowed to develop, especially one where there's increased demand because we have a growing population. There's large flows of state funding, which is quite stable over a long kind of period. You had quite a fragmented market and an appetite amongst a lot of smaller providers to kind of sell to these larger corporations. And then how this market then evolves and changes will always far outpace the ability to monitor and regulate it. And I think you kind of mentioned it, Stefania, these companies are always a step or two ahead of regulators and policymakers. And I think one of the reasons for this is because there's quite a lot of opaqueness in terms of how they operate. And the more information that policymakers have, the increased likelihood that the dominance of these, not maybe in terms of provision, but in terms of how they structure policy will be reduced. But also we would have a more a market and a long-term care structure, which is more about not just profit maximization, but caring for the individuals who are providing care, and also ensuring there's value for money on the part of the taxpayer who are providing the vast majority of the funding to these corporations.
Indeed. Yeah, no, that's brilliantly said, Brendan. And indeed, WHO and many others, in fact, are arguing that we need to transition to quality management systems that go beyond assurance of safe practices in day-to-day care provision, that we need to generate data that looks at the structure of the system, of the workforce, of the capacity, competencies, skills in the sector, so that the data we generate is being analyzed so that it informs evidence-based policy and in a timely manner. We're nowhere close to the timely manner that I think we can all agree with. And even when we do have data and can build the case, it's the time lag often is just too long to get ahead, as you brilliantly put it, these trends. Okay, we have a couple more minutes. Eva, maybe I give you the floor to address the question. Erika, you'll have to remind me the question. You were speaking too fast, I couldn't take note. But Eva might be more on the ball than I am right now.
Eva is completely on the ball. She's already been in the chat, but it's the role of the funding and whether or not things would happen without it.
Yes, great question. Eva. Oh, Eva, you're muted. I see you've started.
Oh, sorry.
There you go.
As I said, I wrote in the chat that somehow we were prepared. Slovenia was somehow, we worked for many years on the reform. So we knew what we want. And then this final push from the European Commission came. So perhaps it would happen. We also had quite strong government in the last 4 years. So, but it was very important, I think. And also the funding of the pilot projects, which happened in 2016, 17, 18. So 3 years of these pilot projects was an important step forward. Yeah.
Ludovico, if I'm not mistaken, the long-term care reform in Italy was also supported non-indifferently by RRF funding, right?
So the Italian one, you mean?
Yes.
Well, partially, but there is a budget issue exactly because of that, Stephanie.
Yeah, okay. So the resources that used to be there and now will disappear, will have to be replaced from national sources. So we have 3 more minutes. I would suggest that we don't take another question from the chat, Erika, but rather go to a final round of reflections from all our speakers. I think what I would most like to know, in the spirit of being pragmatic and focused on the practical challenges of transformation, reform, investment, and long-term care, is that I'd like to go around the panel and ask each one of you, what advice would you give countries on what not to do? What pitfalls do we need to be able to avoid at this point? Because these are mistakes we can no longer afford to be making. Maybe this time I go in the opposite order that we started in the panel, and I put you on the spot, Flaviana.
Yeah, it's both an easy and a difficult question. So I think that what we noticed and member states themselves have recognized is that they are trying to square the circle in a way that they do affordability, availability, quality, but they forget about the workforce. And you cannot increase capacity and you cannot work on quality and so on and so forth for as long as you don't have a crystallized, well-regulated, well-resourced workforce, given the nature of the beast, given the nature of the sector. So it's not something that they shouldn't do, because many have woken up over the last couple of years and are investing heavily in this, but workforce is the thing to maybe do more of.
Thank you, Flaviana. I'm going to go very quickly now to make sure everyone gets their 15 seconds on this topic, what not to do. Brendan, you're next.
Well, Flaviana stole my first answer. So I don't think the state should ever leave the private or the provider market entirely, as they've done in some countries and some parts of Ireland, because once the state leaves a market or reduces its involvement, the flexibility to act for particularly marginalized groups or to provide care if a provider leaves is greatly reduced. So that would be my one thing.
Thank you. Excellent, excellent. Great one. Eva, you're next. What not to do?
I would say that they should not they should actually not avoid to get the financing from all different sources. So from state budget, co-payments, social security. So all diversified financing should be used to get as much as possible public funding.
Thank you, Eva. Very good advice. And Ludovico, the last word?
I would say not to take for granted the level of living standards we have today. That these are the results of public investments in the past decades. And therefore, I would advise not to take this for granted and look at the hidden costs of not acting.
Yeah, cost of inaction. Wonderful. John, 3 seconds before Erica really cuts us off.
Yes, no, I think these were great. Everyone took all of my first choices of things not to do, so I won't waste time with this. I just want to say first, thank you to our wonderful moderator and wonderful panelists. I thought this was a great session. Next week, same time, same place, different people on emergency care. Please join the webinar and please read the Care Dividend book. And until then, yeah, thank you. Have a nice rest of your day.
Thank you very much, everyone. Thank you for staying with us.